And this subsequent randomized double-blinded study found L2 nerve blocks led to significant reductions in pain even at 30 days. A bit more drastic, but perhaps worthy of consideration in some cases, is the possibility of lesioning the sympathetic trunks therapeutically. This was performed in this 1996 paper at the L2 and L3 levels. Subjects who had failed to improve following a lumbar laminectomy operation underwent diagnostic local anaesthetic injections at L2, L3 and L4, after which a total of 15 lumbar sympathectomies were performed. 11 of these sympathectomies were deemed to have led to a satisfactory outcome after more than 6 months. The 4 unsatisfactory results had all had less than an excellent response to these same injections. This tells us 2 things. Targeted sympathectomy can be an excellent option for those with severe chronic low back pain, and that response to local anaesthetic injections can be used to identify patients likely to benefit from this procedure. Take this case study of a 69-year-old female who'd had a fusion from L3 to S1 for chronic lower back and bilateral leg pain. Unfortunately, while this operation helped her severe left leg pain, after the operation she developed 9 out of 10 severity right leg pain, which failed to respond to multiple injections, none at the L2 level it must be said, and a further 2 decompressive surgeries. After referral to a specialist pain centre, diagnostic sympathetic injections were performed, followed by radiofrequency lesioning of the L2 and L3 sympathetic chains. This led to a resolution of her pain and allowed her to cease 3 pain medications. Here is a close-up of a nerve, and in colour you can see the small nerves and vessels which insert into the periphery of the larger nerve. These small nerves are called nervi nervorum and supply sensation to the larger nerve itself. Unlike the signals carried along the nerve itself, the signals from the nervi nervorum are very likely to be transmitted along sympathetic nerves and are therefore visceral. This means that they're poorly localized, resulting in an aching kind of pain. So irritation of a nerve, even without compromising its function in terms of its ability to carry ascending and descending signals, can cause pain. And like other visceral pain, this pain can be referred in a somewhat predictable, if not always exact, pattern. Consider, for instance, the pain around the umbilicus, which usually heralds appendicitis, or the left arm pain, which can signal a heart attack. And the irritation of the nervi nervorum around the larger nerves can be either mechanical, from direct pressure of a prolapsed disc, for instance, or chemical, derived from inflammation. In the real world, we don't have someone poking the outside of our discs. Rather, it's internal disc pressures which are most important. Anything which increases internal disc pressures can lead to stress on the annulus fibrosus and has the theoretical capacity to cause pain. And this was demonstrated in this 1949 paper by Carl Hirsch. He reports on 16 subjects who all had severe recurrent low back pain. Using X-ray guidance, he inserted a small needle about half a centimetre into one or both of either the L4-5 or the L5-S1 discs and injected about 2 mils of saline. This increased the intradiscal pressure and in every subject led to reproduction of their low back pain, identical. He then injected local anaesthetic, which eliminated the pain, proving the involvement of nerves in this process. Nerves we now know which are located in the outer part of the annulus. One thing which is common to all these experiments is that the pain experienced on stimulation of an annulus was always poorly localized and in many cases described as muscular. This is due to the afferent signals from the sinovertebral nerves being carried to the brain via the sympathetic trunk, which you can see here. This makes it a visceral pain, which is like the pain you get from angina or appendicitis, and while aching in quality and poorly localized, it can be severe. Here you can see the pathway carrying the afferent signals from various spinal structures, including discs, the vertebral bodies themselves, epidural vessels, the posterior longitudinal ligament, and the anterior dura mater. These signals are carried along the sinovertebral nerves to the sympathetic trunk, where they ascend before travelling through the L2-3 intervertebral foramen to be carried by the L2 nerve, eventually reaching the brain. Pain from most of the lumbar spine is carried along a single nerve, a sympathetic afferent running through the L2-3 foramen, and this information can be used clinically both for diagnosis and for treatment. You see, if we can block the afferent signals arising from the discs and vertebral bodies and other associated anatomical structures, then we can block the experience of pain. So for instance, if we were to perform a block of this ganglion here, then we may be able to stop the pain signals ascending and reaching the pain, therefore blocking the pain experience. In this study, 33 patients with low back pain had a unilateral L2 nerve block on the side of maximal pain. And during the injection, 29 of the 33 subjects felt reproduction of their pain. And afterwards, all patients reported improvements in their back, buttock, or groin pain, and almost complete disappearance in 26 of them. And the benefits of these injections were not just limited to diagnosis. The average reduction in pain lasted more than 20 days, despite only using a short-term local anaesthetic. It's commonly believed that we have no idea what causes most cases of low back pain. Take this 2017 review article, for instance, which explicitly states that non-specific low back pain has no known pathoanatomical cause. Well, this is false. We have excellent evidence dating back to the 1950s that most cases of low back pain arise from disc pathology, either directly or indirectly. Let's start with consideration of pain arising from the disc itself. The outer 1 or 2 millimeters of the disc, called the annulus fibrosus, has nerve endings from the sinuvertebral nerve, which, when irritated, can cause pain. And this ability of discs to cause pain when irritated has been known for at least 70 years. This paper by a Swedish surgeon was published in 1949. It documents a case series of 200 patients he operated on while awake. He used local anaesthetic to provide pain cover to the tissues overlying the discs, meaning he was able to expose the discs themselves without anaesthetizing them or numbing them. After exposing the intervertebral discs, he probed the outer disc, in his own words, somewhat firmly, to assess the resultant pain response, all while the patients were awake. And in almost all of the 200 cases, he was able to generate low back pain in what was described as a lumbosacral distribution. In other words, irritating the outside of the disc caused non-specific low back pain. Documents a series of case studies in which nylon thread was passed through and around various anatomical structures in the spine, with the free loops left protruding from the skin, then covered by a sterile dressing. In one of the patients, this nylon was looped through the annulus fibrosus of the L4-5 disc, the outer part of the disc. Then, the day after the operation, the investigators tugged on the nylon loop, and after about 30 seconds of continuous traction, the subject described an ordinary backache. In other words, something akin to non-specific low back pain. We then have this paper from 1991. A series of 193 patients were again operated on while awake, using local anaesthetic for analgesia. First, the investigators exposed the tissues of interest, and then, before numbing them with local anaesthetic, they used blunt compression and electrical stimulation to assess the pain response. The major finding was that the outer disc, the annulus fibrosus, was implicated in low back pain. In 2/3 of the nearly 200 subjects, stimulation of the annulus fibrosus always reproduced their pre-operative pain. Not just caused pain, but qualitatively reproduced their pain. The subjects identified the pain produced on irritation of the annulus as being identical to their usual low back pain. Clear evidence that much so-called non-specific low back pain is actually discogenic.